We're going to start back at our first slide.
So I'm going to go back.
This is
All right, so this is part two. And again, I appreciate your understanding and patience. So we'll move forward with presenting about smoking while positive, addressing strategies to improve health outcomes in smokers living with HIV. The overview will be data about the tobacco use prevalence in the state of Michigan, as well as statistics on smokers living with HIV, the impact of tobacco use on people living with HIV, and then what are we doing to address this, right? The tobacco use reduction for people living with HIV intervention, and then providing you some practical resources and referrals. So those of you who might just be joining us, this is new information. For those who are part of the webinar from the beginning, you'll now be able to see the slides that I was referencing earlier. So earlier I mentioned about the adult prevalence in Michigan compared to the rest of the United States. Michigan is in blue, the rest of the United States is in red. There are times when Michigan was below the national average, and you can see that there are some really important tobacco policies that impacted those prevalence rates, and that were the Smoke-Free Air Law in 2010, as well as increased price of cigarettes. There's also the new BRFS, the BRFS, the Behavioral Risk Factor Survey, the different weighted and scoring that also impacted how the tobacco use rates were compiled. As of the most recent data, Michigan is at a higher tobacco use rate than the national average. Again, looking at causes of preventable death, cigarette use and the health complications with cigarette use have a higher impact on people living in the state of Michigan than all of these other health issues. And so complications with your health due to cigarette smoking kills on average 17,000 people in the state of Michigan, which is more than the rest of these categories combined. Looking again at the population disproportionately impacted by tobacco use that have very high rates of tobacco use, you're looking at people living with HIV, which according to our 2015 HIV client survey, about 50% of people living with HIV were tobacco users, low SES, Native Americans, also poor mental health, LGBTQ community, uninsured, Arab American, those with disabilities, and African Americans all have higher tobacco use rates than our state average. So specifically, what does the impact of tobacco use have on people living with HIV? I appreciate the media campaign that DC Tobacco Free Coalition, they have adopted this campaign and public service announcement that they do called Don't Burn Through Your Meds. And so in that picture, you see a medication bottle and cigarette ash at the end and the smoke. And in the small print there, it just kind of gives you an overview, an idea of what is the impact on someone's health when they're living with HIV and they're smoking tobacco products. So we'll look at smoking and the impact on people living with HIV, but tobacco use in general. So we know clients are using smokeless tobacco products. They might be using electronic nicotine devices such as vape and e-cigarettes, or they may be using hookah and not necessarily identifying that as smoking, but it is smoking. So what impact does that have on someone's health when they're living with HIV? It can interfere with the liver's processing of medication. It can cause a quicker progression to HIV stage 3, what most people might note as an AIDS diagnosis, but the public health community as well as medical community are moving away from that terminology of an AIDS diagnosis and stating advanced HIV or HIV stage 3. So it'll have a quicker progression of the virus, interfere with processing of medication, increased likelihood of complications with the medication. So in that small print there in the poster, it said there might be an increase of side effects like nausea or vomiting. It can weaken the immune system because there increased inflammation when there's tobacco use and you have an HIV diagnosis. And on average, people living with HIV can die 12 and a half years sooner from tobacco use than due to their HIV diagnosis. So it is really important that we address tobacco use with people who are living with HIV to ensure that their medication is working effectively and to increase their overall health and well-being. So because we know these really difficult health outcomes with tobacco use, people living with HIV, we really wanted to understand more about clients' attitudes around tobacco use, agencies' understanding on how to engage clients about their tobacco use, assess quitting behavior. And so the tobacco section staff went to the HIV care section in 2014 to do a pilot study. And then we ran the study again in 2017 to see what progress we have made. So this is just an overview of our survey objections from 2015 as well as 2017. So we want to determine what really is the current smoking prevalence, what's the pattern among people living with HIV, assessing knowledge, any change in their belief and behaviors when we did the first survey in 2015, look at demographic and socioeconomic factors among people living with HIV related to their tobacco use, and again, assessing their quitting behavior, readiness to quit, and also what does that look like to access tobacco dependent treatment services in organizations that they're already accessing other services such as medical case management, HIV medical care, early intervention services, pantry, and other supportive services. So the methods of our survey distribution to make sure that it was in compliance with MDHHS IRB, it was approved survey study through our MDHHS IRB, and we wanted to make sure that it was accessible to all clients. So it was provided in a hard copy given to all clients at their ASO, as well as online via SurveyMonkey. They're also able to complete it via a phone interview, and we provided instructions on how to complete the phone interview with staff. And staff were also able to mail the survey with a self-addressed, stamped envelope, so that clients who weren't able to come into the office or have access to a phone or have access to internet to complete online, they could also provide it with a mailed survey. Survey was open for 3 months in 2015 as well as 2017. And for our 2017 survey, we had about 1,485 clients respond. This slide is just showing our statewide prevalence of people living with HIV and some demographic breakdowns and the response rate that we received in 2015 and in 2017 to really highlight that we received a sample size that really reflected what we see statewide. And so statewide in 2017, about 15,000 people are living with HIV. Of those 15,000, 78% are male, 21% are female, 1% transgender. And if you look at our survey sampling in 2015 and 2017, we had a decent sample that reflected those same outcomes of a little over 70% male, over 20% female, and 1% transgender. Results of that survey in 2015, as I mentioned, about half of people living with HIV were tobacco users. We then implemented tobacco dependent treatment services in various AIDS service organizations throughout the state of Michigan from 2015 till currently. And in 2017, the tobacco use rate was reduced by 41%. So about 50% of people were using tobacco products, and now we're a little over 40% of people are using tobacco products. And so I'll go into a little more detail into what that intervention looked like at those agencies, but we're really excited to see these preliminary results on the impact of providing tobacco dependent treatment in community organizations and health departments and health systems. Of course, that would then relate to an increase in former smokers, as well as an increase in clients that were never smokers. Looking at the age groups, the age group with the highest tobacco use rate are the ages 35 to 44, and there was significant decrease in their smoking prevalence from 2015 compared to 2017, so 58% to 44%. In the younger population, again, very significant decrease, 18 to 24 years. In 2015, 48% of those respondents were tobacco users compared to 33% are tobacco users in 2017. And there were some decreases in the 25 to 34 year, but not very statistically significant. And the 45 and more, there were some significant decreases as well. 47% were tobacco users in 2015, and in 2017, 38% are active tobacco users. Looking at tobacco use by sexual orientation, those who identify as lesbian, gay, or bisexual, 50% of those were active tobacco users in 2015 and 38% identified as tobacco users in 2017. Those identified as heterosexual, 50% were tobacco users, and now it's 44% are tobacco users in 2017. And looking at the way that we word our questions around sexual orientation, we received really helpful feedback from our contractors on how to improve the language that we use to make it more accessible, more relevant, to capture more options for how people identify for their sexual orientation as well as their gender identity, and making sure that that's more comprehensive. So moving forward, how we present the survey as well as our findings, we will have some different categories for that. But as of right now, we separate that out for as lesbian, gay, and bisexual, and then heterosexual. Looking at smoking rates by gender identity. Oh, sorry. Going back, so by gender, male in 2015, 51% of people were active tobacco users and 40% are tobacco users in 2017. There were some decreases in those who identified as female, and transgender, very minimal decrease in tobacco use, and that transgender identity includes both trans male and trans women. Again, moving forward, how we capture that data might be different in future surveys to make sure it's more comprehensive and reflective of people's gender expression. Then the tobacco use by race and ethnicity, Black Americans were at 51% in 2015, whereas in 2017 there was a reduction to 43%. There was also a reduction with white Americans from 49 to 40%, and a slight reduction with Native Americans from 57% to 50%, and a very slight reduction in the Latino population, the Latinx, population from 44% to 39%. So there are some slight reductions in the Native Americans and Latinx community, but we are looking into ways to provide tobacco dependence treatment that's culturally relevant to really engage those communities to have some better outcomes moving forward. So this slide I included because it's interesting. The next slide will kind of explain a little bit more, but we looked at attitudes and awareness about the quit line. So if they were aware that there were services available for them through the Michigan Tobacco Quit Line. In 2015, there was very little awareness of the quit line. 2017, there was increased awareness of the quit line. But if you look at this next slide, not too many people access the quit line. So there's increased awareness, but people still aren't really using the quit line as a mode of support for quitting tobacco use. What were some very popular and more successful interventions were the in-person quit classes, the one-on-one individual counseling that tobacco treatment specialists provided in the clinic or aid service organization or health department, and What's also interesting to note is that there were people that were quitting cold turkey without any support in 2015, and there are still some people quitting cold turkey in 2017, but there was a significant reduction in those quitting cold turkey. We know people are more successful if they have other counseling support and medication in their quit attempt, and so that was really interesting to note that people are accessing services, and it's more so the in-person group sessions, medications, counseling with someone that they know and can talk to in person versus the quit line. So increased awareness doesn't always translate to increased usage, but what we did see an increase of are people really using other interventions than just trying to quit on their own cold turkey. The focus group is really more qualitative data, getting attitudes, behaviors, and beliefs on how to improve successful quit attempts. And so the two topics of discussion were what were their influences or motivation to quit, and what did they need to quit successfully. Major themes from our focus groups, which we held about 10 of them across the state of Michigan, and one that was held in Ypsilanti that I facilitated that was for people who identified as women only. The major themes from those focus groups were fear of disease or death. They wanted to quit to improve their health status, environmental changes, increased financial state. They wanted to have some more money, limited access to tobacco, and they were able to quit successfully because they had changes in their environment. They had increased family and support. I note that smoking and tobacco use is a very social experience, but quitting can be very isolating. So people who were successful were in an environment that was supportive, and they had friends, healthcare providers, family, environment that was supportive to their quit attempts. They had increased access to treatment programs and just better coping skills. So some results from the focus group, and these are some really interesting quotes. It takes more than one approach. Oftentimes, providers may just offer one thing, such as medications or the quit line, but clients really responded well to having more than one way to support them in their quit attempt. Someone mentioned that I need a human being support who understands when looking for support, it should be genuine and not difficult to find. Someone noted that my partner smokes, so he would have to quit. So that environmental factor. Finding non-smokers. If you know someone who smokes, you'll hang out more and smoke more. Someone kind of noting how they felt when they quit. I could think clearer, even see and hear better, and I want that back. So really wanting that feeling of overall health and well-being that's really positive. My younger brother died due to complications that came along with smoking, so definitely made me want to stop. So having other family have health complications. Truth commercials suck all of the joy out of smoking cigarettes. I'm not concerned about my health. Saving money comes first, then my health second. So providers are really focusing on the health aspect and not on the other motivations that can be discouraging to clients. So really identify what motivates them to quit. And this is the last one, kind of speaks a little bit to the one prior. It states the ads nowadays are horrible, but you want a cigarette afterwards. So on one hand, some people were discouraged from smoking from the media campaigns around tobacco use, but then others were just so scared and nervous that they were just motivated to smoke more. From the feedback that we received from clients in the focus group, we created a media campaign that was a little more positive. Clients stated that they wanted to be motivated to quit in a way that was strength-based, that what would they gain by quitting? Instead of media messages that focus on what they lose by continuing their tobacco use, what do I gain by quitting? And so they can gain just being out more, having more energy, and having the ability to do the things they love, like cook, garden, be out with their dogs, skateboard. They want to have campaigns that look like them. So we use a variety of different cultures and people and activities that would make it accessible. And these posters also, we have them in a larger size or the smaller size. The small size of these posters on the flip side has a map of all our providers in the state of Michigan where they can easily access a tobacco treatment specialist in their area, as well as calling the quit line. So we will see, because tech issues abound, if this video works. But this is a video that we did in 2017. And this is me when I was a tobacco treatment specialist at Unified HIV Health and Beyond. I look forward to possibly doing another video that doesn't have me in it because it feels fairly self-promoting to have a video of myself. But just discussing my experience being a tobacco treatment specialist, as well as having really powerful messages from clients and their experience of being a tobacco user and living with HIV. So we will see how this goes. Okay. So it seems like we might be having some technical difficulties with the video, so we will send out a link to the video. It is on YouTube. If you just search on YouTube, if you want to look at it on your own, I Will Quit, MDHHS. And as I mentioned, it's really powerful video of two clients and their quit journey and their experience working with a tobacco treatment specialist, as well as my experience as a TTS in the community and working with clients and getting them connected to resources in their area. So because of the time and the tech issues, we'll just skip the video, but we will definitely send out a link so you can access that. So there are some barriers to providing tobacco cessation for people living with HIV. Some of those main issues are just lack of knowledge of impact on disease status and medication. So because there are competing priorities and different things that clients may present to their case manager or to their provider or to the tobacco treatment specialist, that they're just not even aware that tobacco is an important thing to address, that it's really minimized in comparison to taking their medication, having a safe place to live, other comorbidities or mental health, other dual uses of other substances and tobacco use, that it's difficult to engage a client about their tobacco use if they don't really see the urgency or the impact of the disease on their overall health, or if they just have other competing priorities. Some providers aren't even screening for tobacco use. Using my own experience prior to having the training as a tobacco treatment specialist, and I was just a case manager, I would ask a client about their tobacco use during initial intake, and I would not address it ever again. It would just be something that we did during that biopsychosocial assessment, but we really didn't engage clients about their tobacco use. We talked about all the other things that they may have need of and get them access to those resources, but tobacco use just wasn't addressed. Staff feel like they don't have the expertise and the knowledge to engage clients about their tobacco use. Also, tobacco industry is very innovative in how they market to populations and how they want to get their products in the hands of people living with HIV, as well as those who are LGBTQ and just those who are low SES and all those different populations that I reviewed earlier that have those high rates of tobacco use. The tobacco industry does really targeted marketing to those populations. And so we are up against their seemingly infinite media money, and we have to try to combat those messages with the real health impacts of using those products. So we see the challenges and the issues, and we kind of approach the work that we're doing in three different goals. So our goals are long-term, of course, to improve the health outcomes for people living with HIV, midterms to increase the number of quit attempts for people living with HIV, and short-term to really engage staff on the clinical practice guidelines when providing tobacco dependence treatment and really include that in their policies and processes. So doing a lot of capacity building with aid service organizations so that they understand the need and the urgency to talk about tobacco use with their clients and to connect their clients to tobacco dependence treatment services within their agency, as well as the Michigan Tobacco Quit Line and other resources in their community. So our objective and activities to really obtain those goals was to first educate and train staff. So that first fiscal year of 2015 and 2016, we had staff attend tobacco treatment specialist training, as well as motivational interviewing training to engage clients who might be resistant to change and how to address clients in a very culturally relevant way. We wanted to improve data so that we have a better sense of the tobacco use behaviors. So we had that preliminary data in 2015. We did another survey in 2017. We hope to do some more surveys in 2020 around tobacco use and people living with HIV, just so that we have accurate information and that we are using our resources in a way, again, that's culturally relevant, impacting the community that have the higher rates of tobacco use. Documenting these services through CareWare. So if you're not familiar with Ryan White programs, all Ryan White services are documented through CareWare, which is a HRSA-funded database. So all of the medical case management, early intervention services, and now tobacco dependence treatment is captured through CareWare. So integrating tobacco dependence treatment in that software. Also creating expertise. I already mentioned the tobacco treatment specialist training. Our ASOs not only receive this training, but they also move forward to become certified tobacco treatment specialists. And as I mentioned previously, engaging clients using motivational interviewing. So our project timeline, that first year or so was just gathering data. So assessing not just clients, but we also assess staff. So we needed to understand what were staff comfort with engaging clients about their tobacco use, as well as their understanding of the clinical practice guidelines. That next year we really focused on training staff to be tobacco treatment specialists and providing tobacco dependence treatment in a community-based setting. We assessed again what was the impact of providing tobacco dependence treatment in these agencies in year 3, and then year 4, we expanded our contractors to not just those who are receiving Ryan White Part B services, but also Ryan White services in the Detroit eligible metropolitan area. So that is Ryan White Part A. And so we reached out to the Detroit agencies, the Wayne County area, and to increase tobacco treatment services in a population that we know have higher rates of tobacco use. And now we want to focus on innovation. So we have a few agencies that are piloting peer support specialists, and we are looking at really specializing our treatment. So as I mentioned before, we heard feedback from staff as well as clients to make sure that the treatment that we're providing is culturally relevant. So if we're talking about reducing stress, or we're talking about clients who want to quit smoking but they're concerned about weight gain, and you suggest, oh, join a gym, but they may not have resources to join a gym, or they may not have a safe area where they can go out for a walk. How can you engage them about stress relief and coping strategies that are relevant to their living expenses and their experience in the community and in the world? This is just a map of the agencies that we are working with. The circle is the circles are the AIDS service organizations, health departments, and health systems that we fund to provide tobacco dependence treatment with those living with HIV. And the triangles are LGBT organizations that host thinking about quitting pre-contemplation classes and health education around tobacco use and the LGBTQ community. The intervention that we encourage agencies to adopt is the 5A's intervention, also known as the Clinical Practice Guidelines for Tobacco Dependence Treatment. And that is ask, consistently screen clients for tobacco use, advise clients to stop using tobacco products, and assess their willingness to make a quit attempt, assist them in making that quit attempt, and arranging for follow-up. So the 5A's, for some people, when they first started doing it, they saw it as really a burden, that this is a lot to take on as a case manager. This is a lot to take on as a medical provider when you're already addressing a host of issues in a visit with the client. But we did a lot of training to show frontline staff, whether you're someone working in the reception or someone in the pantry, or you're a case manager, that you can do the 5A's intervention in less than 5 minutes. That it can be very conversational too, that when you're advising a client to stop using tobacco products, you can advise in a very strength-based way. It's not necessarily advising saying tobacco products are bad, you need to hurry and quit, and clients might feel judgmental. But if you advise about the benefits of quitting and making it relevant to them in their life, assessing their readiness to quit. Are they ready to quit in the next 30 days, in the next 6 months? Are they willing to speak with someone else further about their tobacco use? Would they like to have a follow-up conversation about it? So maybe they may not have time to talk about it today because what's most urgent today is food, is a gas card to go to their next doctor's appointment. Definitely address what clients are presenting in that moment, but using the 5A's can be really brief, and it needs to be made relevant to the client, not intrusive, not judgmental, and constantly doing this cycle. That's why I love this image, because it is a circle, this cycle of follow-up, and constantly doing that with every client at every visit. So not just in adopting the 5A's intervention, we want to make sure that this is institutionalized with agencies. And so we focus on health systems change. And this isn't just something that's done in a clinic, but we're all working in some sort of system, whether you're community-based or a health department. And so how does your program really talk about tobacco with clients? And so if you're a health system like a hospital, you may want to look at your EMR functionality. So we had all of our hospitals look at their electronic medical records and see how are they capturing tobacco dependent treatment services, looking over how could they revise their policies to ensure that there's consistent engagement with clients about their tobacco use, using the 5A's consistently across medical staff, reviewing protocols to improve documentation, including tobacco dependence treatment in their quality management plan. So many Ryan White providers have a quality management committee that is focused on plan, do, study, acts to improve service delivery. So some of our contractors are doing PDSAs specific to tobacco dependence treatment, and then ensuring that there's ongoing TA with clinic staff around tobacco use. So it's not just making sure that staff know what the clinical practice guidelines are, but really having consistent training to make sure that they're doing it successfully, that it's not a burden and that's not a challenge to them. As I mentioned, quitting is something that should be a supportive social experience and not isolating. And so we have a few agencies that are piloting a peer intervention. So not just working with a tobacco treatment specialist or their case manager, but they're also working with someone else who's living with HIV, who is currently tobacco free, and that person will help them facilitate support groups, be a buddy with them to go to their appointments with their TTS or to their other providers. They can supplement the TTS with some one-on-one coaching. And so looking at the model that we see in the recovery world with sponsors and peer support and other substances, we want to use that same model with tobacco use, because tobacco cessation programs sometimes can be really isolating and can honestly be intimidating to clients, that they're going to someone that they don't typically know or talk to, and they're going to talk about something that they may have been a tobacco user for years. And so having a buddy to go along with them through that process, we hope can improve health outcomes as well as increase quit attempts. So now we're in our 5th year of the program. We have quite a few lessons learned, and we're excited about some new opportunities, not just with the peer program and focusing on health systems change, but we recognize that there are some limitations to our funding. There's some challenges to integrating tobacco dependence treatment services and careware. We tried doing this tobacco domain to capture all that information, but there were problems with that. And so really working closely with the careware staff and the HIV care section to make sure that we're capturing the data and the services accurately, that it is reporting what the TTS is putting in there accurately. The importance of gaining buy-in from agency staff, so case managers, early intervention service workers, clinic staff, frontline staff that may be receptionists or work in the pantry and other supportive services. We have to make sure that it's a multidisciplinary approach. So that means all staff have to have an understanding of the clinical practice guidelines. All staff need to understand how to track this in careware. All staff have to be committed to doing this. As I mentioned, recognizing the limitations of our funding, this program is funded through the HIV Care Michigan Drug Assistance Program rebate dollars. And so it is specific for people living with HIV. And we may have clients who their partner or the people that are living with them are HIV negative and they're tobacco users, and they want some of the same services as the client who's living with HIV. And so we have some limitations on what we can do, but I applaud our contractors for being really creative and innovative and really engaging them and referring them to services in their area. Right now, tobacco cessation services are covered under those essential health benefits. So for a lot of people who have health insurance, connected them to a quit line that is with their health insurance, or connecting them to the Michigan Tobacco Quit Line, or to services within their clinic where they go to for their primary care. So people have been really creative in how they engage the partners and support systems of their client living with HIV on their tobacco use. The need for more culturally relevant training. And so as a tobacco section, we've been going through a lot of cultural proficiency trainings, implicit bias, and we've been encouraging the agencies that we contract with to do more culturally relevant training so that they are able to individualize and specialize the treatment. As I mentioned, suggesting someone to go to the gym, but they don't have the money for a gym membership, that's not helpful. So how can we provide tobacco cessation services in a way that's culturally relevant? Talk about tobacco use, but making sure that we're specific about commercial tobacco use, because there's sacred tobacco use in certain communities. Making sure that we acknowledge the very predatory marketing that the tobacco industry has done in the Black community and the LGBTQ community, and making sure that our tobacco cessation services are culturally appropriate, that they're relevant, and that we approach this work with a lot of cultural humility, that clients are the experts on their lives. When we might have a lot of expertise on tobacco dependence treatment, the client is the expert on their lives, and having them inform us on how they would like their tobacco dependence treatment and tobacco cessation services. As we do that, we're excited about opportunities that we're partnering with other agencies and other organizations that are doing work in those communities to provide trainings for the tobacco section as well as our agencies. So we've been looking into providing trauma-informed care, healing-centered engagement, training around the transgender community, training around menthol in the Black community. And so we are excited that we have seen this type of feedback, and now we have the opportunity to grow in our understanding and our just professional development. And lastly, developing community-informed work plans and services. So initially, we held everyone to the same work plan and standard on how they were to implement tobacco dependence treatment services. Now, all 16 funded agencies have specialized their work plan to reflect the community that they serve. So what works in Detroit may not work in the rural area of the Upper Peninsula in Marquette. And so how do you provide these services in a way that is reflective of the community that you serve? So we're excited that agencies now moving forward have a very specialized work plan that will do that type of work. Lastly, you'll see these next few slides are just links, and you will have a copy of this presentation at the end of the webinar. And these links are just really valuable resources on the impact of tobacco use for people living with HIV. The VA has a really great handbook, HIV Guide for Clinical Care, tobacco use and behavioral methods to engaging clients, quit attempts. ATEC has a really good handbook that was developed in 2014. Smoking and HIV at HIV stage 3, as I mentioned, we're using that terminology instead of what people may commonly understand as an AIDS diagnosis. We're using the terminology of HIV stage 3 or advanced stage of HIV. Our YouTube video that I will quit, as well as the YouTube video for Brian's story, Tips from Former Smoker Who's Living with HIV. The CDC has a story of someone experience of living with HIV and what motivated them to quit. Also, YouTube video that kind of explains that terminology of HIV stage 3. And then we have other resources for providers. So access to the clinical practice guidelines, the CDC tips campaign, and various toolkits that hopefully will be helpful for you to make some practical steps to implement a tobacco treatment program in your agency. And also resources for clients that might be an app for their phone. There's the QuitNet online program, Become an X, and there is information about Nicotine Anonymous support groups. American Lung Association has another amazing program called Freedom from Smoking, which all of our agencies have been trained on how to host those clinics to encourage people in their quit attempt. So I encourage you to click on those links and gain some more understanding and resources and skills. So I appreciate, again, your time and your patience as we work through our tech issues, but I will open it now for questions, and I believe there might be some in the chat box already.
So thank you so much, Yana, for that wonderful presentation and managing those tech issues. You were a trooper. I'm going to jump right into the questions. So again, if you have any questions, please submit them in the Q&A box to the right of your screen, and we'll make sure that we get to those. But one question that did come through is that you mentioned the thinking about quitting classes. Could you talk a little bit about the structure of those programs? How are they coordinated, and maybe participation? Because I know there are tons of people that are thinking about quitting, so I definitely see them as maybe a warmer way of introducing someone into treatment.
Yes, the thinking about quitting classes are for people who do not have a quit date, that have zero desire to quit tobacco products, but might be at some point want to address or talk to someone about their tobacco use. So the way the class is run right now, there are some people in LGBT organizations that are hosting these classes, so they make it really relevant to the LGBT community. And so they just kind of have a conversation and engage, well, why do you use tobacco products? What is it doing for you? And talking about the stressors that you might have being someone a part of the LGBTQ community. And so talking not necessarily about quitting, but just talking about tobacco use, how it relates to them and their culture and in their community, and then what would it look like if you did think about quitting? What would it look like if you made some steps to quit? And so that's how those classes run. It's typically like just a 1 day or a few hour workshop where it is a presentation going over just information about tobacco use and the LGBTQ community, and then more so a dialogue where they're talking about why do they use tobacco products and what will it look like to possibly quit. So it's not for people who are highly motivated to quit. It is definitely for those who are in pre-contemplation and who haven't, made any attempt to do anything. And it is, as you mentioned, Elena, that really non-judgmental, very soft approach to getting people to dialogue and think about their tobacco use differently. And then possibly at some point, hopefully, they will want to address their tobacco use.
Yeah, thank you for that. That's definitely something that we should possibly consider implementing. So yeah, I'd love to hear more about that. So the next question was that you talked a little bit about the importance of getting buy-in from everyone within the clinics. I'm wondering what are some ways that you've worked to get provider buy-in, and also maybe what type of pushback you've gotten.
So I'll start with the challenges and end on a positive note on what we have done to make some really good progress. So the challenges have been with providers who are infectious disease providers. They may feel that their focus is only on the HIV. And yes, they want the clients to quit. They talk about it at every visit, but they feel like tobacco cessation is a primary care provider's problem. It is someone else's issue that they just literally don't have the time to deal with that. So it's been my experience that ongoing TA and ongoing conversation. So what I mean by TA, that technical assistance, that they understand that screening for tobacco use and referring to a TTS is not trying to add more burden to their plate during that very brief, maybe 15-20 minute time that they have with a patient, but it's really going to help the overall purpose that the infectious disease provider have, which is to improve the health outcome of their clients. So as long as they see that doing this process of the 5As isn't burdensome, but going to be a help overall, then providers tend to be a little bit more motivated to utilize the 5As. Also, I've seen that a lot of clinics and even in the community-based setting, getting case managers and others on board have been really going over at every staff meeting. So a lot of our tobacco treatment specialists, they have time on every single staff agenda that they talk about tobacco use, that they go over the 5As again with clinic staff, that they go over how to put this information into CareAware and document it consistently and accurately, that that's a part of their grand rounds and the health system staff meeting. It's also a part of the community-based organization staff meetings. And then when I was a tobacco treatment specialist, I used to do SAC lunch and learns, so sometimes if I had the funding available, I could bring food, or if I didn't, I would just say, hey, if you brought your lunch, if you have 20 minutes to meet with me in your conference room to talk about tobacco use. And for the most part, I would get 5-6 providers who would have the time to sit and talk and listen to me ramble along about tobacco use. But once they got the information, they were highly motivated to refer clients to me. So I would get clients from the HIV clinic that may not even been active clients in case management with her agencies. They would get referred to our agency for tobacco dependence treatment because the front desk staff, the MAs, the RNs, they sat in on a discussion that I had, and now they're like, oh, did you know that there's hope, when they do that tobacco screening? Because in most health systems, tobacco use is right there when they do the vital signs. So they're checking blood pressure, temperature, all those things, and then they're asking about tobacco use. So that tobacco use in the EMR kind of triggered them to say, oh yeah, I just sat in on a training on this. We just had a lunch and learn about this. There's someone at Unified that you can talk to for some help. So that helped, was just having that ongoing conversation at staff meeting and then lunch, food, and having a conversation over food about tobacco use got some people on board. And I think having other providers talk to providers too. Dr. Gulick in Lansing has been a huge champion for us, and he's been talking to different providers. And I think that that's really helpful when a provider sees another infectious disease doctor really taking this on and being a champion with it. They're more motivated to do this work too.
Yeah, exactly. And we definitely see that on the health system side here as well. I feel like as tobacco treatment specialists, it's definitely, a part of our job to heighten the issue of, how important tobacco treatment is. So thanks for your work there. So we do have a question. So have you had any feedback from clients that being asked so often has been burdensome?
Yes. So I haven't heard it directly from a client, but I've heard it from frontline staff that are EIS or case managers or non-medical case managers, that they're tired of asking the client. And then when they do ask, the client's like, oh, again, did you just ask me this when I saw you a month or so ago? So yes, it can feel frustrating to a client because they're already being asked at every single clinic visit. They're being screened, at their primary care doctor's appointment. And now they're being screened when they're coming just to get a bus token. So yes, clients can feel over it. My feeling is that I understand that it can feel overwhelming. I also wonder, how are they asking the client?
Mm-hmm.
And so if you're just asking about their tobacco use every single visit, just like that, saying, oh, well, what's your tobacco use like? Are you using tobacco products? Are you using tobacco products? Are you a smoker? Yes or no? That can feel very frustrating and can feel invasive and irritating and annoying. But if you ask from a strength-based perspective of someone who's a non-smoker or a former smoker, oh, hey, you're still not using tobacco products, especially if you already know their status, you can ask it from that point of view of like, just want to congratulate you on staying tobacco free, and use that as your way of asking. Because then they can say, oh, you know what, I slipped up and I was at my cousin's house and smoking. And that's happened to me before, where I was asking a client about their tobacco use, but in a very conversational way. They came in for pantry and I said, oh, you should be coming up on a year or so being tobacco free. Oh, girl, I'm back to smoking. Oh, okay. Well, now it's a conversation. Oh, you want to talk about it? If someone is a current user who has no desire to quit and they feel like you're being judgmental by asking, again, ask them in a way that doesn't feel burdensome or feel judgmental. And that can be, I see you're still a tobacco user. How's that going for you? It's going great. It helps me reduce my stress. Oh, okay. Well, at any time you want to change that, or you want to, kind of learn a little bit more about how that's impacting your pockets or your health, come talk to me, and so it's all in the way I think that you phrase it. Because if you are looking at it as the checklist and not really engaging the client, then I think it can feel irritating. But if you're looking at it from a strength-based point of view of congratulating them on continuing being tobacco-free, or if they're currently a tobacco user and don't want to be bothered with you, just putting it out there like, how's that going for you? Are you still using tobacco products? Okay, no changes. I see that you're a tobacco user. Are there any changes? Putting it that way so that, nope, no changes at all. Okay. And just making it really conversational and specific to the client versus it being intrusive, judgmental. Like, I know you about to bug me about quitting again. Here go that tobacco lady, because I was a tobacco lady at my agency. So I can see where it can be frustrating, but I think it's all in the way you do it.
Yeah, definitely. So another question, for people living with HIV, do you find barriers for your clients for getting nicotine replacement and quit medications, and any strategies for dealing with these barriers?
So a success that I didn't mention, and this was in our year 2 of the program, is that all of the 7 FDA approved medications for tobacco dependence treatment are covered under the Michigan Drug Assistance Program. So that's MIDAP. So we are funded through the MIDAP rebate funds from HIV Care. And within HIV Care, MyAdapt is a coverage for medications that are related to their HIV diagnosis as well as any other co-diagnosis. And now all of the 7 FDA approved medications are covered under MyAdapt. Majority of the clients that we work with qualify for MyAdapt. And so access to any of the medications, NRT, Chantix, or Wellbutrin, they have access to it as long as they're eligible for MyAdapt. If they're not eligible for MyAdapt and we're going through their insurance, I've heard from some tobacco treatment specialists that they've experienced some barriers, but they've been able to get access through the pharmaceutical company, contacting them directly, using other funds that they may have to purchase that, and making sure that the client have access to the patches or the gum, working with their pharmacies. A lot of our AIDS service organizations have these partnerships with pharmacies, or they're in the same building of a specialty pharmacy, and those pharmacies will give the clients NRTs as well as the other medications as long as there is a prescription for it. So that has been an amazing success that we saw within the second year of the program, because it can be challenging that someone wants to quit but doesn't have access to the medications to help support their quit attempt and the nicotine addiction. But we were able to establish a great partnership with MyAdapt to include that in their formulary, and the pharmacies that all of our agencies work with have been doing an amazing job of making sure clients have access to the medication if they want it.
So the next question is, what has been one of the most successful ways to stay quit for former smokers? Example, cold turkey, one-on-one support, etc.
I think that depends on the client. What we have seen based on CareWare, so in CareWare, the tobacco treatment specialists, they know when they have assisted a client with an intervention, when they complete an intervention, and those interventions are individual counseling, groups, health education, thinking about quitting, using the quit line, using tobacco dependence treatment medication. The most used intervention and the most referred intervention and completed intervention is always the individual counseling. And then underneath the individual counseling, it is medication and then health education. And so I think most clients respond really well to having a person that they know, that they can see face to face, so they can meet not just in the office. I commend our programs for being really accessible. So the TTS will go out and meet the client at McDonald's, at their home, go for a walk at the park, go and meet them at the library, talk to them wherever they can. We have agencies that have a cell phone so they can text the client. And so that has been amazing. So having that one-on-one counseling in a way that's accessible has been probably the most utilized intervention. And then medication, we know people are twice as likely to be successful if they have some sort of medication, especially those who are highly addicted to tobacco products. So having nicotine replacement therapy or Chantix or bupropion, Wellbutrin, having some sort of medication to help them as they're going through withdrawal symptoms and things of that nature. I think that has been the most successful. And then education classes. Clients are responding really well to thinking about quitting or just basic health education. So we have a few agencies that will host health education class that is focused on eating and nutrition, and then they'll also talk about tobacco, or maybe focused on just overall healthy choices and what does that look like if you address your where you eat, where you sleep, and also your tobacco use. So how does that look if you start addressing all these different areas in your life, and what would your life look like if you start making some steps to improve your health? And so financial literacy, like people will host a class about health in general, health and wellness, and then in some way find a way to kind of slip in tobacco too. And I think clients have been responding really well to those health education classes, and that has increased quit attempts and people in their maintenance of quitting tobacco. I think if clients also, when they're meeting with the TTS one-on-one, have a relapse prevention plan. So talk about relapse. Relapse is a part of recovery. There will be slips. There will be relapse. How do you come up with the strategies and plans to prevent it? And then also when it happens, what's going to be your strategy to move forward and to continue in another quit attempt? And so I think that one-on-one client counseling, when the TTS addresses relapse and recovery, can really set up a client to be successful in their quit attempt.
Definitely. And I'd like to just add a little bit to that since I work with patients individually in our outpatient clinic on relapse prevention plans. One thing I tell my clients constantly is you have to stay busy, right? Having those distractions, because we know boredom can be a huge trigger for tobacco use and relapse. So scheduling time, especially during that first month or so of being quit. And you mentioned the nicotine replacement therapy and the cessation meds. One thing that I see commonly with slips or relapse is because someone will quit and they'll stop using that nicotine replacement therapy. So really focusing on the fact for those medications to be effective, and what we're dealing with is your brain chemistry there. For you to have that adjustment and those nicotine receptors in your brain to become inactivated, it takes about 3 months. So continuing to use the medication and giving our clients and patients that information to make it very relevant for them, but also help them understand what's going on in their body. Another thing that we do is look at what are your withdrawal symptoms and how are you going to cope with those. So a lot of times I'll have clients that say, I'm coughing more now that I quit, and this makes no sense to me. And I'm like, that's your body clearing itself of what you used to take in. So embrace the cough. Hopefully it's temporary, but really kind of giving them as much information as we can for them to really understand what's going on in their body can be helpful. So another question that we got is, have you found a connection or partnership working with people with HIV, with mental health issues within different mental health agencies?
Yes, so quite a few of our agencies that we contract with have behavioral health specialists on staff. And so that might be someone who is a social worker, or they're connected with mental health programs in their area or within their health system that they can refer a client to for ongoing assistance for clients who might have dual diagnosis of addiction with other substances, or they might have a another dual diagnosis of another mental health diagnosis too. I remember working with someone who, the more I worked with him, the more it was identified that he had some generalized anxiety disorder too, and that smoking was how he was kind of self-medicating and working through that. And so I referred him to the behavioral health specialist within our agency to start working, just kind of brought it up to him as a conversation of, this is what it sounds like you might be dealing with. Are you open to talking to a mental health provider, a behavioral health specialist, or a social worker, or a counselor, or therapist to kind of explore having anxiety and those racing thoughts and dealing with that. So he was open to the referral. And so it is definitely a collaborative approach, because the TTS can only do so much. And a client might be dealing with something that is way more intensive when it comes to their tobacco use, because tobacco use is just their way of kind of self-medicating whatever that they may be dealing with. So there may be some undiagnosed mental health issues. There may be some, clearly identified and diagnosed ones. And so we encourage the TTS to work with the mental health provider, whether it's within their agency and within their community, to make sure clients have access to care that is appropriate for all of their health and well-being, which includes their mental health. And so we know that people with mental health diagnosis have higher rates of tobacco use. And so we definitely encourage them to collaborate. And I have heard fairly successful experiences with getting people into treatment. I know mental health providers, it is few and far between. It's really difficult with community mental health because they only have so many appointments, and sometimes they can't have an appointment until very, very far out into the year. But a lot of the agencies have behavioral health specialists within their agency, so that's good too, that they can kind of have someone there that can triage until they can get into a more intensive program.
Oh, thank you for that. So here's just a comment by Paula Peters, and thank you so much for this comment. So as a medical provider, we ask questions that often seem redundant to patients. but need to be asked every visit. For the most part, they understand, but occasionally a patient becomes annoyed. And as Shiana mentioned, we just address it, that we address the patient and their reasons for frustration. So yeah, definitely using kind of some of those really good MI skills to reflect how they're feeling back. I tell people all the time, you're probably tired of talking about your tobacco use. You know, I get it. So thank you so much for that comment. So you mentioned that the state is funding 16 agencies across the state. I'm wondering, are there going to be opportunities for additional funding, if that's something that you can speak on, or I know funding kind of fluctuates as we see with the quit line sometimes. So, but if any information, because I think here in Michigan, we have some unique opportunities for what we're doing with collaboration with the state and different health systems across the state where we really can address the tobacco epidemic.
Yeah, so excuse me, I'm so glad that you brought that up. So yes, we currently fund 16 agencies, and as I mentioned, the program in the very beginning was just a pilot to do some surveys and to do this intervention and see what our outcomes were. And so we moved in 2018 from a pilot to a fully funded program. And so yes, we do have sustainable funding right now. And for fiscal year 20, we will be releasing an RFP, a request for proposals. And so we definitely want to expand our funding because we know that there's more than 16 agencies working with people who are living with HIV. And so the funding is specific for people living with HIV and doing tobacco cessation. And we really want to encourage agencies that have some innovative practices, that have some creative ways to engage the community, because it can be difficult when you have a community and a population that have multiple issues and concerns and other competing priorities, lack of resources. How are you really going to provide this treatment in a way that is culturally relevant and is going to be effective? And so with that RFP, we're encouraging people to apply and to make sure that whatever services that they are providing, that it's done in an innovative way and that really reflects their service areas. So when you know your population that you serve, you know whether it's rural, whether it's a city environment, whether you may have just 1 or 2 counties or 10 or 20. So what would that look like to provide tobacco dependent treatment for that service area? So we definitely have some funding available, and we will have more information on our RFP in the next year. And we encourage anyone who's working with people living with HIV to apply.
Well, thank you for that. We'll definitely be keeping our eyes out for that. So that's about our time for today. I don't see any additional questions in the Q&A box there, but I want to thank you so much for presenting today and for everyone that attended the webinar and bearing with us through some technical difficulties and the work that you do. We definitely appreciate you. We'll send out an email with slides and the recording. We'll also have a link to that YouTube video that we weren't able to play. So have a great day, everyone, and thanks again for attending.